Okay, so welcome to TGCT Registry webinar. During this webinar, as you can see, all participants are on mute and their mics are currently muted and your video is muted. However, I want this to be as didactic as we can have it, so please feel free to put an emoji out there, ask a question, and I'll unmute you. It was more, this is recorded, and so anybody who unmutes themselves or puts their camera on will be part of the recording. My name is Sydney Stern. I'm the Director of TGCT Programs at TGCT Support, and I'll be your moderator and I'll be the presenter today. I'd like to thank our sponsors, EMD Serono, Decipher Pharmaceutical, and Daiichi Sankyo. And thank you all for spending your, for some of you afternoon, for some of you evening, and even for others tomorrow morning. So I'd like to get started. Let me share my screen. Okay. Can everyone see my screen? Someone want to throw out an emoji to make sure that they can see it? Okay, perfect. Thank you. Okay, so as some of you may know, our registry data was published for the first time just in April, although this was a long time coming. Many of you know that we started the TGCT registry in September of 2022. And that was a culmination of inspiration from both life raft groups, a patient registry, and the community. We all ask questions regularly about what's going on with each of us, and there has to be a way to collect that information that informs decision making and patient experience and potentially informs providers. So it was just published. You can find three patient versions currently. One on the left is in English. The one in the center is in French. Thankfully, TGCT Support France is a big collaborator with us, and Arthur took the job of translating it, as well as the last one, which is over here, and that's in German. And we had some lovely German patients that collaborated to help us make sure that that was accessible to everyone. We're currently in the process of making a Dutch version. And so please, if you have an interest in taking the information and making it into a version or translation for people who speak a similar language, we would love that. And we love that collaboration. And this can be found on the TGCT support website at our research tab. Some background. I don't need to give you guys a big background about TGCT, but so we all start at the same place. TGCT is a rare, locally aggressive tumor. It affects an area of the joint lining called the synovium, the bursa, which is a fat pad that helps with shock absorption, or a tendon sheath, which is the outside of a tendon. There are two distinct radiographic subtypes, which means by MRI, there is a diffuse type and a localized type. They tend to be distinct, but as many of you experience, you live on a spectrum of sometimes more diffuse and more localized. Ultimately, TGCT is based off of a chromosomal aberration. This means that it's a genetic disease that only occurs within the tumor cells. So only 2 to 16% of those tumor cells actually have a completely abnormal part of a gene that causes it to grow. The rest of us are entirely healthy. There's an unmet need. Telling you guys that is kind of a funny situation because we all know that there's an unmet need. These symptoms are highly nonspecific. They range from asymptomatic to debilitating pain, swelling, stiffness, and loss of range of motion. It's a rare disease, which means that patients often have a significant delay in diagnosis, and they may have many misdiagnoses before they get adequately diagnosed. And this is all a relic of the fact that it's really hard to diagnose something that most providers have never seen. And so, as I said, patients can present in complex ways and they're unpredictable. I often get asked, why watch my disease? Will I get worse? And the answer is we don't know. And that's part of the difficulties with treating this disease is we don't know everybody's long-term outcomes. And because symptoms range so much, you could remain asymptomatic for a very long time, if not never develop symptoms. However, we do know that recurrence, particularly with the diffuse disease, can be very common, and local recurrence is cited around 50%, but as you'll see in our data, it can be sometimes higher than that. Questions still remain about the impact of TGCT on quality of life, how long patients have TGCT, how impacted they are, how does it affect their daily life, can they perform their daily activities? Are there challenges or barriers associated with care? These are all things that we take for granted in the community as like ahas. We know these exist, but having something documented is really important when you try and develop solutions. And so we took upon ourselves this analysis of our ongoing registry to describe the burden, what it's like to be us, and the treatment journeys experienced by patients. Let's see if I can go to the other side. Okay. Because I'm talking to a diverse group of patients and other people who may be watching, it's really important that we use the same language. Um, Orthopedic surgeons or sports medicine surgeons, these are general orthopedic doctors that specialize in operating on skeletal or anatomical structures. Meniscus tears, cysts, things like that would be seen by orthopedic surgeons. And generally, orthopedic surgeons fall into a general category or sports medicine where they focus on a specific area of the body, like upper extremity or lower extremities. Orthopedic oncologists are medical doctors that have specialized training in surgery, which particularly treat tumors. Orthopedic surgeons may cut through tissue. Orthopedic oncologists know to cut around tissue. And so you'll see that there's some differences in even just the surgical techniques in your own experience. It's important to note that while the word oncologist is described in orthopedic oncologist, they do not prescribe medication typically. They are only specialized surgeons. And so when we talk about medication, we often talk about medical oncologists. These are doctors with specialized education in diagnosing and treating tumors with medication. This can include soft tissue tumors like TGCT or sarcomas, which are cancerous. It's important to note that TGCT is not cancerous. There are two different types of approaches surgically. The open synovectomy, which is a surgical technique that uses a large incision somewhere between 6 and 12 centimeters to gain access to the joint and remove the synovium or the lining of the joint. Sorry, I was converting inches and centimeters in my head because the diverse environment that we all are in is really important. We keep to the metric system in science. The last approach that you'll see surgically is arthroscopic synovectomy, sometimes called the arthroscopy. And this is a surgical technique that utilizes multiple small incisions. They're little tiny ones, like 3 centimeters. And they insert a camera, which is called a scope, and a tube that's inserted. And the camera allows the surgeon to visualize the inside of the joint, and it projects onto a monitor behind them. And that surgeon will use those other small incisions with surgical instruments to cut and remove the damaged tissue. What we see is that when tumors are above a certain size, so 3 to 4 centimeters is the common reference point, that if it's above a certain size, it cannot be removed through a scope without cutting directly into it. And so you'll see that there's this combination approach between orthopedic oncologists and orthopedic surgeons that may refer to one another based off the size of the tumor or whether it's diffuse and in multiple compartments of the joint. So it's very, very patient and individualized. So we wanted to gain information about what treatment strategies are done, what works for patients, what doesn't work from patients, how they feel, how they function after any of these treatments, and how they experience the disease before diagnosis, during diagnosis, and after. So essentially, we wanted to uncover everything that was going on. And we had this information. You all have been part of this information, or many of you. And so we wanted to start analyzing that information. And so we took the baseline data, which was a cross section. A cross section just means we're taking a snapshot of what we're looking at. And so anybody that replied to the registry, we took the baseline data and we wanted to look at the history of that person. And so anybody who replied to the TGCT support registry between October 6, 2022 and December 6, 2023, this should be 2023, we looked at your information and developed trends. And so what we started with was 832 entries. So people who just replied to the registry. What we found is that some people didn't actually hit submit. So it's really important you submit your data. We found some duplicates, which is totally fine. That's why we clean data. Patients may switch their name or they may get married or they may have other things. So the number, the unique identifier that you get was not attached to the person that actually filled it out. So it said you were 2 people, even though it was the same person. And then some people had incomplete data. So once we cleaned that data out, we found that we had 625 patients, and then we excluded anybody who was under 18 and anybody who didn't consent. It's really important when we talk about any sort of data that affects humans that consent is part of the process. And then what we ended up having is a population of 497 patients that we could look through your information and start to develop trends. Currently, we have more than double this. So that is a testament to how amazing you guys are and how dedicated you are at getting this information to us. It's worth noting that, kind of as a pat ourselves on the back, that this registry is international observational perspective and is the largest one globally. It's comprised of 168 patient-centric questions. It's now a little bit more questions. So thank you all for considering how much time that this takes to fill out, continuing to fill it out longitudinally every 6 months. We really appreciate it. So who did this data capture? Essentially, who are we? Patients were how you read this graph and how you look at it. I'm moving all the things away, all of the notifications away. Okay, so 355 patients that reported into the data set had diffuse disease. 94 patients had localized disease, and 48 of you said, I don't know which one I have. Totally fine. And so that had then 497 patients you see here. When we start to separate who's in the diffuse category, who's in the localized category, who's in the unknown category, and who is everyone, we can start to pick out trends that may affect certain subgroups more than others. And while it's worth noting that we are really good at capturing the diffuse disease, it is the minority of patients in the real world setting. Localized disease is 85% of patients. So most people who have TGCT will have the localized form. When we looked at who we are, patients were mostly female. We have 74% were female, and this is relatively similar across all of the groups. Patients were young. We're 45. We go from 18 to 81, so we span every type of person you could imagine. When we look at how many are located in the United States, we have 56% in the United States, which is similar among diffuse and localized. This has changed a lot. Our data set now is more equal, or at least entirely equal. And so you can see that that may influence some of the treatments that are offered to patients. The knee is the most common location. 68% reported the knee. That doesn't differ between diffuse disease and localized disease. It's really important we say that because the localized form is the most common form, but it's most commonly found in the hands and in your feet. And one reason why you may see that our registry reflects patients who have mostly in the knee disease is the naming. TGCT, as many of you know, was called PVNS at one point, giant cell tumor of the tendon sheath, and all of these other names. And most of the patients with it in their hands and feet were named giant cell tumor of the tendon sheath. So they may never have found us. They may never have found this registry. They may never have found this group. And when we look at who's employed, 64% or 65% are employed full-time or part-time. So this entire population is young, employed, and very well educated. Nearly 60% of the patients who responded to our registry have a university degree or higher. In the United States, 37% of those individuals have a degree, and if you get above 25, it's only 40%. So our registry reflects people who are more educated than the general population. And that may just be because you're searching for information. When we look at who the demographics are made up of, as I said, you have 71% have diffuse disease, almost 19% have localized disease, and almost 10% have an unspecified, meaning you didn't know. When we look at our lovely map, you can see that 56% were in the US, at 43.7% were in other areas, such as the Europe, with the most common locations, Germany, France, and Italy. You have both India captured in our registry and other areas of Asia, and then as well as Australia, New Zealand as also well captured. We also have in South America, you'll see that we have a lot of patients in Peru and Brazil as well as Argentina, and that's also reflected quite nicely. We have 48 countries represented, and it's really important that we keep it as diverse as possible so it reflects everybody in our community. When we looked at patients' age at diagnosis, Patients currently are 45, as you saw, but when they were diagnosed, a lot of them were 38. And you'll see that that spans from 7 years old to 74, which means we have, again, a very large span of patients who are diagnosed and as well as patients in our actual registry. It's worth noting that a significant number of patients were diagnosed in the last 6 to 7 years when there were systemic therapies and there were more options available to them than just surgery. Often, when we look at how clinical care changes over time, time is the biggest component. We know more with more time, ideally. So it's worth noting that majority of patients have had the benefit or some amount of benefit of the new information and advancement. When we look at everybody, 50% of patients were misdiagnosed before they received their diagnosis. Misdiagnosis and diagnosis in general can be really complex. So this may be misinterpreted, where you may have gone to your doctor. They may have said, "Oh, you have a cyst. Let's take a look," and then you were diagnosed with TGCT. That intermediary step of, "Oh, this could have been a cyst," patients sometimes misrepresent that or think that that was a misdiagnosis. So there is some complexity involved in how you report this. But importantly, we know it's high. We know patients are often misdiagnosed and they're often seen by providers that maybe shouldn't be the ones treating them. When we looked at those who diagnose providers or the diagnosing provider, so the provider responsible with your diagnosis of TGCT, overwhelmingly, orthopedic and sports medicine doctors make up the majority of those. Very small percentage, around 1/5 of patients are seen by an orthopedic oncologist that diagnoses them, as well as you'll see less for a medical oncologist, rheumatologist, general practitioners or primary care providers, and then other usually encompassed radiologist or PT or anything not seen above. From those patients who had symptoms to their diagnosis, we wanted to figure out how long. How long are you affected by this disease symptomatically before you actually receive a diagnosis? And unfortunately, what we found is over 50% of patients spend more than a year looking and having symptoms before they get their diagnosis. And so what that shows us is patients are absolutely spending too much time in this period of delay. And so, as you saw previously, we have here that most patients did not receive their diagnosis until more than 12 months after their symptom onset. This is data you saw previously, just in a different way. I like to show data in multiple ways. A lot of people are not used to looking at data, and that's totally okay. So if you don't like the tables, these bar charts are another way to look at it. This is where we have a percentage, and you can see that 61% of patients were diagnosed by an orthopedic surgeon, 50% were misdiagnosed. And if we look at just 2 years, 33% of patients spent more than 2 years looking for their diagnosis while they were symptomatic. So just different ways to look at data. Primarily, the misdiagnoses included Baker cyst or other unspecified cysts like ganglion cysts. Arthritis, we commonly hear that in the group. Rheumatoid arthritis, which is a immunologic disease or autoimmune disease. It is not just a degeneration of a joint. A specific type of gout that actually develops these masses. Fibromas, and then all sorts of sports injuries, tears, bursitis, meniscus tears, scar tissue sprains, and then a few patients are actually misdiagnosed or thought to have sarcoma. Usually this is based off the location, like those with it in the spine or those with that outside of the joint. And I see a chat that there's a question. Just excited about data. We're totally fine with that. If you guys want to ask a question, please add an emoji and I will I'll take you off mute and you can feel free to ask. I know it's a lot of information at once and there's so many ways to explain it. When we looked at some of the main symptoms that led to the diagnosis, you guys have seen some of this data already. Here's the providers that diagnosed you. Here's that time it took to be diagnosed. But when we start to look at the symptoms, what is the number one symptom that led patients to be diagnosed? In diffuse disease, you can see that it's swelling. Patients get these huge joint swelling. You guys know it gets huge and it's very hard to misinterpret that something's wrong at that point. And you'll see in the localized disease that swelling is actually a little bit less common. For those with localized TGCT, pain was their number one symptom. And these were different. These are bolded because there's statistics that say that these are actually different, that it didn't just happen by chance. Overwhelmingly, pain for everybody was the most common symptom when we don't separate by specific subtype. So once you're diagnosed, now what happens? Most patients are told 90.7, so 91% of patients are told that surgery is their main option. 16% are told medications may be an option for them. 5% are told about clinical trials. 15% are told about radiation as an option. Hopefully, this is historic and that we see a change away from this. As many of you know, radiation is no longer an acceptable form of treatment for TGCT when there are other options available, and typically there's other options available at this point. 3.4% are told amputation is an option. Again, this is less and less common. And then 28% are told that active monitoring, just watching the disease, is a option. This is surprising because what we know about the disease and what we know about other research done by other providers in the space, like Randall et al., um, and Bernthal et al., and there's a few publications, is that a lot of patients can actually wait around a year or more before they start treating. And so this underutilizes potentially just watching the disease, that you don't always have to remove it. When we looked at other treatments discussed, you'll also see when we broke it down by drug itself. So we have surgery here. We still have that 91% that you saw. When we break it down by drug, Turalio or pexidartinib is talked about in 8.7% of cases, and imatinib or nilotinib, two other drugs that are used off-label, you can see 7.2% are told about this option. In clinical trials is that 5%. So overall, patients are not really told that drugs are an option at any stage in their journey. So we talked about who diagnoses you. Then once you're diagnosed, who actually treats us? Um, when we looked at who treats patients or at any point whether a patient received treatment from one of these doctors, you found that 74.7% were still treated by orthopedic and sports medicine doctors. It's many of you know it's hard to get out of sports medicine. That tends to be the initial point of contact, and most people do receive some form of treatment by an orthopedic sports medicine doctor. When we looked at orthopedic oncologist, 62% said that that was their treating provider, which is a shift. We see from here you have 23% and you see a shift to 61%. So patients are getting to a place that could be the potential best option for them, which is a sarcoma center that is commonly treating tumors. You see that 2% of patients are diagnosed by medical oncologists and 28% are treated by them. A lot of us ponder whether this is underutilization of this group of people. If there were drugs that were safer, more options available, easier accessible options for everybody, would that number go up? And you'll see that's commonly pondered within the field. Is this truly just being underutilized, or do patients not want to go on drugs? And I think what we see in our environment is that when given adequate information, patients are more willing, but when patients aren't given the option, they don't have the option. Rheumatologists have a role in treating the disease. This is often represented globally. So in France, for example, TGCT may be treated by rheumatologists still. So you'll see that there's some global influence in these numbers. 37% of patients are treated by a physical therapist, and that is outside of surgery. So there was a role for learning how to move, and what exercises may work for you during physical therapy. General practice, you'll see your primary care may take a role, maybe prescribing different drugs and different things, but you'll see that commonly. A radiation oncologist or a radio oncologist has 9.7% of people have been treated. Those are the patients who are often treated with radiation. Again, we are getting away from this. And you'll see anything you could imagine falls into this: palliative care, pain clinics, and other doctors that may participate in treating of the side effects or symptoms related to the disease or treatments. I put animations, if only I'd use them. This is another way of looking at that same information, but just by diffuse versus localized. So if we see for diffuse disease or localized disease, orthopedic sports medicine and orthopedic oncologists are still used in the same amount, same frequencies. In theory, I would have expected diffuse disease to see orthopedic oncologists more often, and that's not the case. And there's no real difference, period, between who's treating diffuse disease and localized disease except medical oncology. The drugs for TGCT are typically reserved for those with diffuse disease or those with localized disease in life-threatening locations like the spine. So now that we talked about what options were given to patients upon when they were diagnosed, let's talk about what treatments patients actually received. And so if we remember that the arthroscope or arthroscopic surgery or synovectomy is those little holes that you stick in and you put a scope in or a camera and you can remove things based off of looking through a camera. You can see that localized is in green and diffuse is in blue, and we have the percentages here that 34% of patients with localized disease were treated by arthroscopic synovectomy, and for diffuse, 47% were treated with this approach. Of open surgeries, 44% were treated with an open surgery who had localized disease and 47% with diffuse disease. So there's actually no difference. Neither of these are different statistically in whether localized disease is treated by an arthroscope or open, which starts to get into conversations about recurrence rate, and that in data, it's hard to decipher whether these technical approaches actually have meaningful differences in recurrence. Meaning, if you have a scope or if you have an open surgery, the recurrence rate seems to be the same. That is likely confounded, meaning that there's so many other things that influence it, like surgeons' experience, where you're going, how many surgeries you had prior. So it may be that we just can't decipher the information the way it's presented now. What is noteworthy is that when we look at those who have combined synovectomies, which means that they had an arthroscopic synovectomy in the front or usually of the knee, and then they had an open surgery of the back of the knee, you can see that there is a difference. And patients with diffuse disease have more open combined approaches. That's because they need to typically get to the front and the back of the knee. And so that at least shows the difference there. 43% of patients have said that they monitored their disease at one point. This may be just monitoring between surgeries. This could be monitoring after surgery. So we didn't really well define what this looked like. But patients do monitor their disease at some point for both localized and diffuse disease. As I said, systemic therapies are really, when I say systemic therapies, I mean medications. And these medications are really reserved for those with diffuse disease or more complex situations. And so you can see that 24% of patients with diffuse disease were on a systemic therapy and only 3% of those with localized. And as I said, those localized patients could be those with it in the spine, or they have locations that are just a little bit that you can't treat surgically, so they have to be treated with something. Joint replacements are also more common with those with diffuse disease, and radiation is more common with those with diffuse disease. I did look at the data, and you can look back into the actual papers, but if we look at US versus non-US, there's no difference in who's treated with a medication. The types of medication differ, but who receives medication is the same. We have approved therapies in the United States, so that's why that's surprising. So despite the availability of therapies in the US, we don't have a difference. And I think that this may change with more approvals, more options, but this was an interesting finding, and I think interesting to other scientists and doctors in the field. This is another way of looking at that same data in a table format. So these are the ones, the A's denounce that it's statistically different, which means it wasn't due to chance. These are different because it's actually different. And so as you can see, the arthroscopic synovectomy is different. More diffuse patients received it, 47% compared to 34% in localized, 19% in that combined, which we talked about. Joint replacements, patients with diffuse disease are more likely to have a joint replacement. And then when we talk about medications, 24% of those with diffuse disease are having or on these medications, whereas only 3% or 3 individuals were on medications who have the localized type. So you just saw this. If we focus on surgeries, so these are the 3 types of surgeries or joint replacements, you can see that patients on average had 2.7 surgeries. Most patients had around 2 surgeries, with a minimum of 0 all the way to 13 surgeries. And when you look at the diffuse disease versus the localized disease, diffuse disease, patients had more surgeries. You had 2.8 compared to localized, which had 1.8. So we're capturing people we assume we're capturing. On the most commonly, patients had 3 surgeries with the diffuse type. So most patients in our registry, especially those with diffuse disease, had multiple surgeries. And again, most of these patients are diagnosed within the 6 to 7 years. So that's 3 surgeries in 6 to 7 years for most people. One of the things we really wanted to understand is recurrence, as you can probably imagine why that plagues a lot of us. And so when we looked at those who've had surgery, 393 patients had surgery at the time of our analysis. And when we look at the number of recurrences, so we defined it as the number of recurrences after surgery because you can't have it recur if it's never been removed. So that was the logic there. And so of those 393 people who had surgery, 23% had no recurrence after, 26% had one recurrence, 37% had more than 2 or more recurrences, and 14% weren't sure. They may be monitoring, they may be too early, they don't know yet. If you combine these two, that's more than 50% of patients. It's 63% of patients had a recurrence. So recurrence is common, unfortunately, in our disease. And I think we all have kind of realized this, but it was good to have numbers. More importantly, also, what we found was that once you have one surgery, the chances of having a recurrence after your second surgery is higher. What that also means is that repeatedly going into that joint may not actually be any help. There's this myth within our community and within the medical community that joint replacements may be curative. I think all of us in the community has done a really good job of dissuading this belief, but we needed data. And so what we found is that when you've had a joint replacement, 24% of patients had no recurrence. 11% of patients had one recurrence, and 56% or more essentially had 2 or more recurrences. And so when you put these two together, you get 67%. So those with joint replacements often have recurrences. It is not a curative treatment by any means, and it's really important that it's not treated as a curative treatment, and it should be used when patients have degenerative joint disease, which warrants it as part of a discussion with your doctor, not to treat TGCT. So when LRR means the local recurrence, so just within the joint when it recurs, and this is another way of looking at the same data. So you see that 62.6% of people have a recurrence. When we look at the diffuse type versus the localized type, diffuse type, it's overwhelmingly more common. 72% almost had a recurrence versus 34%. For our localized patients, this is kind of high. This is higher than in literature, which may represent that we're really good at capturing patients that are severely suffering from the disease and that may be suffering more than the typical patient. What's important, though, is that recurrence is high for those with diffuse disease, and that shows that there's an unmet need, which we all know. These are not new findings for you and me, but it's new findings and numbers for it for the community. For those with joint replacements, again, those are overwhelmingly those with diffuse disease, and those with diffuse disease had a 73% chance, or had 73% of them had a recurrence after their joint replacement. So really important. So we didn't just want to put numbers on everybody. It's great to think that the depth of the experience is insightful, but putting numbers to it don't capture it the same way as experiencing it yourself. So we tried to show what it's like to experience the disease. In our registry analysis, all patients had at least one symptom associated with TGCT. That included pain, swelling, limited range of motion, and stiffness. So regardless, every single person, it didn't matter if you had localized disease or not. More than half of patients reported that pain or physical function impacted their daily life. So it's a disease that impacts all of us a little differently, but all of us at some point, or more than half of us at the point of this registry. And a quarter of patients with TGCT reported changing their occupation or retiring due to TGCT. So not only is it impactful to our daily life, it's also impactful to our occupation, to our ability to make money and financially grow, ability to have family, and be a contributing member of that family. And so it's really, really important that this is captured, and we're grateful for everybody that participated to capture this. And so when we look at the actual data of who retires or who changes their occupation because of TGCT, surgery plays a role. So of those with 0 surgeries and said that they had changed their occupation or prematurely retired, 12% of them, or 13%, had no surgery yet. So TGCT alone was causing some amount of disability that caused them to change their job or retire early. When you've had one surgery, it went up to 20.6% or 21%. When we look at two surgeries, it stayed stagnant at that 21%. But when we look at two or more than two surgeries, you see that those that prematurely retired or changed their occupation, almost 40% of them had more than two surgeries. This means that surgery itself can have an impact on career and disability. And so you'll see with a lot of the interactions we have with providers and how we talk about it, and even the educational content we produce, that it's geared towards this idea that too many surgeries can be a bad thing. So this is kind of the summary of all the data I went through as if it was a patient. And so a patient presents at a doctor's office with these symptoms. The main symptom was pain. You guys have seen this. Most patients, or nearly 56% of patients, go more than 12 months with symptoms before they're diagnosed. They're diagnosed often by orthopedic surgeons. A very small number, 24%, are diagnosed by an orthopedic oncologist. Other providers may be involved in diagnosis. Patients are often misdiagnosed. You have 50% being misdiagnosed. And in other patients, which we didn't really go through some of this part of the data, but for symptoms, patients treat it with a ton of things. Patients treat it with Tylenol or over-the-counter medications, paracetamol for those outside the US. Non-steroidal anti-inflammatory drugs, or drugs that are meant to reduce the inflammation, is a common treatment and the most common. Nerve medications, narcotics, steroids, in draining the joint. These are all used to treat the symptoms of disease. These do not treat the disease itself. Patients are largely treated by orthopedic surgeons. A small amount of them are treated or referred to these orthopedic oncologists, and medical oncologists are generally underutilized in comparison. Surgery is the most common treatment. You'll see that there's a bunch of different types of treatment, but surgery is the most common. And there's no real difference between the outcomes of these surgeries, where at least 63% of patients have at least one recurrence. When we look at follow-up of disease, 18% of patients had no follow-up after their surgeries. For those that did have follow-up, only 29% of that follow-up was because of the doctor. 66 or 67% of that follow-up was because patients relapsed. They had symptoms again. They said, wow, this still hurts. Let me go back. And so a lot of this journey is patient initiated, and you all know this. You have to constantly go back to your doctor and say, hey, this isn't working. Hey, I need more. I need to go somewhere else. You're constantly being the ones that drive treatment. And we have data that support that now. So that is the gist of the many slides, but I want to give people time to ask questions. And we did all kind of immediately get a question. Or one of the patients here, please feel free to unmute yourself if you'd like, but you had asked in the chat that COVID and COVID vaccines are around. Apologies as well for butchering some of this question. But we know that the disease has been diagnosed, in this prevalence of disease have been pretty stagnant throughout time. It's not like it's becoming more common. It may be better diagnosed and patients are seeing the right providers faster. But it is not a relic of COVID or the vaccine. And it's a good question because it's asked frequently. I think patients are always searching for a reason. But COVID or vaccines in general are not going to be the reason here. TGCT existed way before this. We're just better at capturing it now. And there's no bad questions. So please, for anybody who's curious about even causes of disease, we do have some helpful webinars that go through more nitty-gritty the causes or potential causes. And I think those are really helpful. Okay, so someone is asking whether pediatric data is similar and why they were excluded. It's really important that when we bundle things and when we talk about consent, it's fit for the purpose that it's being used for. And so when we consent patients to be part of this registry, you know what it's being used for. It's being used for research, it's being used for educational purposes, and it's really important that patients who have potentially could be more exploited, like children, like pregnant people, like uh, inmates in jails, we view these people differently because their rights are viewed differently. And so the consent for patients in pediatrics are a little bit more complex, and the considerations are more complex. There's no drugs approved. There's for pediatrics, and there's only one trial that even enrolled individuals who are under 18. And so when we talk about disease in the context of treatment, it should be in reference to something that's useful for everybody. And so we are presenting data at ASCO, the American Society of Clinical Oncology, at the end of this month about pediatric patients alone. And we're very excited about that. And you'll probably see webinars related. But it's important to separate those in these analyses so it's useful to people who are reading it. But that was also a good question. Okay, what can this data be used for? I love that question. And so the best answer is that the sky could be the limit in many ways, but it's really important we talk about the limitations of data and how things are looked at. And I actually have a slide that didn't show up for limitations, so we're gonna roll with it. I'm so glad someone asked, so I could keep back on my track. So the limitations of this data and potentially what it could be used for. Like all observational data, it relies on you to recall. We have patients, as you saw, that were diagnosed at 7, and we have patients that were diagnosed at 74. It requires you to recall all of your history, all of the information, all of those conversations you had. And so you could imagine if you misheard something or don't remember something accurately, that would be also reflected in our data. Our study shows that patients are young, well-educated, and many work full-time. Particularly that patients are well educated and that patients are largely diffuse disease of the knee in some of these locations, that may not represent every single person. And so our data represents exactly who fills it out. It doesn't always represent every single person. And then lastly, some of the limitations include that we have more females. Females are more likely to participate in registries. They're more likely to participate in Facebook. They're more likely to participate in social support activities. And so this may be just a relic of who's involved with TGCT support, who comes to support groups, who interacts, but not who actually has the disease. Because we know in literature that there is not that big of a difference by sex for TGCT. In literature, recurrence for diffuse TGCT and localized TGCT, for diffuse TGCT, it's around 50 to 70%, and for localized TGCT, it's around 15% or less. Our analysis shows that recurrence rate for diffuse disease was around 72%, and for localized disease, it was around 34%. So these are higher than the numbers. And it may be because it's truly higher in a real world setting when you don't have a clinical trial that watches patients so well and does all of these extra testing. Or it could be that we represent the most severe patients. And both are okay, but it's important to keep that in mind when you read data. There's a lack of standardized follow-up in the real world. Many patients are never seen. They go years without seeing a provider. They don't see the same providers. And so there's not a lot of follow-up in our disease. And there's also no clear definition of recurrence. So whether someone recurs, meaning that they have symptoms that come back, or whether they had a scan that was clean and then that scan showed growth, that's not well defined. A lot of times when you hear recurrence, when we talk about it, it means anything after surgery. But if you never had it removed, then it would grow from a place it was already there. So we call that residual disease. But it's not well defined whether recurrence actually includes residual disease or the growth of something that was left behind, or just symptom relapse or a clean scan and then a growth of disease. So all of those count as limitations and should be considered when you talk about the data or what you think about it. So getting into how does the real world setting compare to this? So this is what we call real world setting. It just means it's what we capture from patients that affect every every lifestyle, every location. It doesn't have the influence of specific experts and things like that. But when we look at the consensus guideline, which shows a paradigm in which patients could be treated based off of, we see that most patients are diagnosed by community orthopedics and they're not in specialized centers. The recommendation is patients go to specialized centers. Patients don't typically get told that they can just monitor the disease. And so active monitoring of that disease is really underutilized in the real world setting. The authors in the consensus guidelines suggest that this actively monitoring disease would be appropriate, particularly for those that are asymptomatic or those managing symptoms, because it would weigh the risk of treatment against the possible benefit. And so if you aren't going to benefit symptomatically from surgery, a lot of times the preference is to just watch the disease, and that's underutilized in our real world data. Surgery is the preferred approach for patients who can have surgery and are symptomatic. That was aligned. And patients only occasionally saw medical oncologists or those that prescribe drugs, while recurrent and diffuse patients should have multidisciplinary care, which is defined by the consensus. So patients have 2, 3 surgeries. Why aren't they getting more options is something that we're all kind of interested in. Specifically, the consensus paper emphasizes the importance of managing TGCT within these specialized centers. So there is options available, whether you take them or not. What we do know is that symptomatic relapse and recurrence is really common with our disease, and that's shown in our data, it's shown in the consensus. And patients often have repeat surgeries. So our conclusion for the data was that it revealed that patients truly struggle with the disease. Patients are often delayed in their diagnosis or receive incorrect diagnoses. They have disease recurrence and often have repeat surgeries even after a joint replacement. TGCT often negatively impacts employment status, particularly in young patients who've had multiple surgeries. It's really important that we raise awareness, so thank you for being part of that awareness among clinicians to facilitate diagnosis to be faster and more effective treatments and better algorithms to reduce recurrence, improve all of our lives, and reduce the impact of disease on our ability to function in society, but not just as individuals in society, but people who have families and friends and want to live a life that isn't full of TGCT, I guess is a good way to put it. And educational efforts should target patients that or providers that are most visited by young patients with recurrent joint pain that doesn't go away, that flares up, that doesn't have a known cause to reduce delays in the diagnosis and improve the paradigm. And so we're actually proposing this as a potential educational strategy, and you'll see our education to be targeted towards that. And I did see another question. So the person asked, is there any genetic markers that predict TGCT or recurrence? There is not. We don't know who's going to recur based off genetics or markers, mostly because a lot of people recur, right? So a large population of people. It's more based off of whether you can remove the entire mass or the entire disease in one go without cutting through it. That is the biggest determinant of recurrence. And that's often why orthopedic oncologists are involved in our care, is to entirely remove it in one go. But with diffuse disease, it's really hard to tell where it starts, where it stops. And so that slows the ability or completely makes it impossible to actually remove entirely the disease. For asking about research related to ethnicity, there's not a lot of data related to that. Unfortunately, clinical trials are skewed towards white European descent. And so the data is not really built out for other ethnicities. That said, we do not believe that TGCT impacts ethnicities differently. It's not more common in a specific population, and it seems to be common across all populations relatively equally. So those actually in the other location that has some reasonable data related is China and parts of Europe. Again, we don't have a lot of data regarding like African ancestry in other areas of the world due to accessibility issues and all of the issues that come with, I think, just rare diseases in general. We kind of take what we can get in rare diseases, but hopefully that becomes future prospects. And for TGCT support, one of our ongoing projects in the future is to look about how socioeconomic status affects care and affects outcomes as well. So hopefully we will gain more information about what truly affects patients, including race, ethnicity, socioeconomic status. I hope that answered the question. For those curious as well about genetic markers, there is data and research going on that looks at how to evaluate scans and whether you can predict patients with recurrence. And so patients with nerve entrapment, so meaning the disease is up against the nerves, or with tendon involvement, those patients are at the highest risk of recurrence. I think it's like in the 90s%, if it can be even removed at all. And so there are little markers in imaging in which you can tell when patients may recur, or whether it won't be removed at all. And so those have been more successful than looking at specific genetic markers or even joint markers. So signaling molecules within the actual joint don't seem to be as helpful either. So someone asked, what's next then? I love the question. Thank you. Um, our goal is to keep building out this registry. It's really important people continue to respond to it, and continue to expand, so we represent everybody and we represent patients that don't have disease that's extremely symptomatic, that doesn't have, burdensome disease, as well as patients that are struggling. I think that that would get the full continuum of the disease. Unfortunately, patients who don't have disease or who are doing really well are the least likely to participate. Why would they want to participate when they're moving on with their life? So if you do become one of those patients that moves on, please remember the importance of filling out the registry. So hopefully we can continue to have data built out about even risk factors one day. Longitudinal, we're looking at data over time. So now that we do have drugs in the market, we do have other options. How does that actually change what people are offered? How many patients go off of these medications? Do they successfully go off? Is there a type of surgery or technique that actually benefits before or after another treatment? When are people most likely to recur? All of those we can actually answer, but we need patients to participate in the registry. So another plug, I'll forever plug the registry, but super important. And that's hopefully the next steps. You'll see a pediatric one, that we're going to do, a pediatric webinar or a pediatric presentation and webinar, related to data. And you'll see some other subgroups, as well as like whether symptomatic patients can be treated differently than asymptomatic patients. A question, is that there any data included about comorbidities? There is data that we have currently with comorbidities. We have not published that data yet. Currently, it's all over the place. Patients are healthy otherwise. And so normal things that would impact patients are still going to impact you. 1 in 8 women have breast cancer. We assume 1 in 8 women who have TGCT will one day have breast cancer, right? So we're complex creatures, and unfortunately, a lot of things can still happen to us. And so what we're seeing is that in the data, there's nothing currently that stands out, besides misdiagnoses, but from comorbidities, meaning diseases that co-occur with TGCT, we haven't found anything really insightful yet. But we see everything from diabetes to breast cancers to other cancers, not in more frequency, just reflecting the environment, skin cancers, um, cardiovascular related diseases, hypertension, things like that. But we're hoping we can potentially find some more information regarding comorbidities, and maybe there's something special about us. We just haven't identified it yet. Yeah, of course. So I will also put a plug as we near the end of the webinar and give you guys time also to keep asking questions. Just a reminder that research costs money, sad face. We do submit these to research articles, to conferences, etc., and it's all based off donations. So I do want to put a plug to consider donating. Your donations help this research. It helps other research. So just there's my little plug for it. And you can find the donation on the TGCT support website too. I have so many screens going. Sorry, guys. Um, okay. Last question. So someone asked, you mentioned medications and going off medications. Do you have data related to people going off medications? We do. We have a lot of data about patients going off medications. Within the registry, which was published data, 64% of patients that were on medication remained on medication. Um, Importantly, though, it seems like the patients that go off of the medication, there's two reasons. Side effects, which is understandable, or a combination of that they wanted to try something else. So they may have wanted to try surgery, Cost, there's always this cost factor. We don't often discuss it. Cost and accessibility is a big one. Switching insurance companies was another one. And so this data is available in our current publication. We do have information that we plan to publish in the near future related to how long patients go off of it, what's the optimal time frame patients go on holidays and things like that. So we have captured that data and plan to publish/present it as well. Well, if there aren't any questions, I'd like to thank all of you for attending and thank you for listening to me talk for an hour about data. Enjoy your Cinco de Mayo, and we do have a TGCT Day of Learning in California on July 12th. So please feel free to attend that. It's a free patient half-day event where you hear amazing talks from amazing speakers who are experts in the field. So thank you, everyone.